Hello, I'm Dr. Praveen Tambrallimath, Senior Consultant Cardiac Surgeon. In this video, I would like to present mitral valve repair in rheumatic heart disease in pediatric population. In Southeast Asia and developing world, rheumatic heart disease is the most common cause of mitral valve pathology and can be seen in pediatric patients as early as 5 to 6 years. With this video, I would like to show two cases of mitral valve repair techniques which can be helpful for other cardiac surgeons. Case 1. A 7-year-old girl presented with a history of rheumatic fever 2 years back and she is on rheumatic prophylaxis. History of dyspnea on exertion since 1 year. Echo showed severe mitral regurgitation. Left ventricle is dilated with a normal left ventricle function and mitral valve pathology was type 2 A2, type 3A, P2 and P3. Here you can see the mitral valve is pliable with dilated annulus, E2 is prolapsing and restricted PML with severe eccentric mitral regurgitation. Mitral valve assessment performed, we could see a PML restricted and E2 which is prolapsing. Now the annuloplasty sutures are taken and then the PML peeling is performed. But inadvertently I created two holes in the PML. So these holes are closed primarily with sixoprolene sutures. So this is the first hole which is closed and this is the second hole which is closed with the sixoprolene. The secondary chordae which are restricting are released so that the restriction is released. Now the E2 segment is seen showing that the large segment at the center point there is a gap where there are no primary chordae. So one primary chordae was cut and sutured so more medially so that we can have a primary chordae at least 4 to 5 millimeter distance, and this is a secondary chordae of A2 which is transposition to A2 primary segment, so that there is a sufficient chordae at each segment. The saline testing is performed which shows a competent valve. The annuloplasty is done with 28 size CG future ring, but we can see a small gap with residual MR at P1 P2 segment. So this segment is now augmented with autologous gluteal layer fixed pericardium. Now saline testing performed, I see a competent mitral valve without any mitral regurgitation. Post-operative echo shows a competent mitral valve, no mitral regurgitation or mitral stenosis. The coaptation height is around 6 to 7 millimeters. There is no mitral regurgitation seen. This is our second case. A 12-year-old girl presented with history of rheumatic fever 3 years back, presented with acute carditis, congestive cardiac failure and atrial fibrillation, for which we started on medications. Patient had twice gone into pulmonary edema, for which she was put on ventilator and extubated. Once the pulmonary edema subsided, then we took her for mitral valve repair. Echo showed severe eccentric regurgitation, dilated left ventricle, and mitral valve pathology was type 3A, P1, P2, and P3. In this echo, you can see the PML is restricted and fixed, and the pseudos prolapse of AML. And there is a coaptation defect between the AML and PML, severe eccentric MR, and a dilated annulus. Because patient had carditis, we can see adhesions of the pericardium to the heart surface. Adenolysis was performed and then put on cardiopulmonary bypass. Mitral valve assessment is performed. Now the annuloplasty sutures are taken. All the secondary chordae which are restricting the PML are now released. Peeling of the PML is performed now. This peeling helps the PML to become more pliable. The peeled segment is cut off from the PML at the rough zone. Now the saline testing is performed, which you can see that mitral valve is competent. The mitral annuloplasty sizing is performed with a ring. 30 size ring, that is Medtronic 3D profile, is used for annuloplasty. Now the saline testing shows competent mitral valve. Postoperative echo shows competent mitral valve without any residual mitral regurgitation or any stenosis, with a coaptation height of around 7 to 8 millimeters. Thank you.